we'll email you. We will let you know. And so we're going to move forward now, and it's my honor and privilege to introduce just a great clinician, researcher, and friend, Dr. Alex Lepak, who's going to talk to us about some pretty cool work done with Acinetobacter baumannii. So Alex, I give it to you.
All right. Well, hopefully y'all can see the slides clearly and hear me okay. I want to start by thanking Jason and the organizers for inviting me to present on this. And, this will certainly be a little bit of a shift from Tom's presentation in that we're primarily going to cover a lot of PK/PD work, a lot of animal model work and pharmacometric modeling that was done by the ICPD folks. And unfortunately, not really a lot of clinical data to really inform susceptibility testing interpretive criteria here for Acinetobacter. So I probably don't need to do much background for most people on this call, as I'm sure you're all very aware of the complexity and the difficulty that comes with Acinetobacter infections. So you'll hear me refer to it probably frequently as ACBC, but Acinetobacter is a common cause of nosocomial infection, especially pneumonia and bloodstream infection. Depending on the study, greater than 10% of nosocomial bloodstream infections are due to Acinetobacter. In some geographic regions, up to a third or 36% of nosocomial pneumonia cases are due to Acinetobacter. And while those are nosocomial numbers, if you follow the literature closely, there really is a concerning and rapid rise of community onset infections that we are seeing from Acinetobacter as well. There are limited therapeutic options. And for many of those options, especially the older drugs, there is limited knowledge on how best to use them. As Jason opened this meeting, newer drugs that are going through approval, we have really nicely done preclinical studies, lots of PK/PD, lots of modeling. So the newer drugs we know how to use quite well. It's the older drugs that were approved many years ago that have a much more limited understanding. So we wanted to look at 4 of those listed here: ceftazidime, ciprofloxacin, amikacin, and minocycline. And one of the reasons to do that is that the susceptibility breakpoints, in some cases, don't even exist from some of the groups that have set them. And for ones that do have susceptibility breakpoints, they were set many years ago with very limited understanding of the PK/PD characteristics of these drugs. And so the aims are shown here. They're relatively straightforward. We wanted to use in vivo mouse infection models to enumerate PK/PD targets from thigh and lung model infections. We then wanted to use that data, surveillance susceptibility data, population PK estimates, and to really integrate all of those to come up with target attainments and to use that data to try to inform what would be rational susceptibility breakpoints, at least in our mind, given the limited clinical data. So I just want to orient you to the next 4 slides, give you some background just on what the distribution is, at least for the United States and Europe, when we think about MIC values for these 4 drugs. And so this is data provided from the Century program by JMI. And so here is the amikacin distribution. And you're probably used to looking at figures like this, but along the y-axis is the proportion or percent, and along the x-axis are the different MIC values. And the different colors here are for 4 different groups. So we have Acinetobacter isolates from the United States in blue, Acinetobacter isolates from Europe in orange, carbapenem-resistant Acinetobacter isolates from the United States in the gray color, and carbapenem-resistant Acinetobacter isolates from Europe. And I've added in the MIC50 here just to kind of help show you some of the differences in the distribution between whether you're looking at USA versus Europe and all Acinetobacter isolates versus those that are carbapenem resistant. And so for amikacin, you can see, for example, the MIC 50 in the United States is an MIC value of 2. It is much higher in Europe, and obviously shifted to the right for both in terms of carbapenem resistant isolates. This is ceftazidime, kind of a similar a story here, where the MIC 50 for the United States is at a MIC value of 8, and it is much higher for Europe and for those that are carbapenem resistant, where the vast majority are greater than 32. For ciprofloxacin, kind of an ugly looking figure here, as for almost all situations, the ciprofloxacin MIC is quite high. Really only in the United States, again, for the for all Acinetobacter isolates, the distribution shows an MIC 50 of 0.5, but otherwise it is quite high. And minocycline's pretty interesting here, actually. It's a very wide distribution. And again, differences between the US and Europe, and differences between carbapenem resistant strains and those that aren't. But you can see, again, the United States is much more to the left versus Europe, and the carbapenem resistant isolates are shifted to the right. So that's just some background, hopefully, as we walk through and we're talking about some of these isolates that we looked at in the animal model. And then when we talk about target attainment, it kind of sets some sort of perspective to where the distribution exists. So let's get into the animal model studies. We had a large library of Acinetobacter strains that we could have selected from for the animal model. And highlighted here in red are the 5 isolates that we ended up using. I think the important point of this figure is to just demonstrate that we wanted isolates, and we were fairly successful in finding isolates that had MIC variation. If you have a variable MIC in your animal model, you are going to have more robust data than having all the isolates have the same MIC value. So we certainly wanted to do that, but MIC value is not the only necessary criteria that you would use in terms of deciding which isolates to use in the animal model. A really important factor that that goes measured but often unmentioned is making sure that the strains are equally fit and grow equally within the model that you're looking at. So the 19 strains on the previous slide, we screened all of them in the animal model. And by screening them, what I mean is that we infected mice in the thigh and lung, and we did not treat them. And we looked at the relative growth over 24 hours. And hopefully you'll appreciate on the right-hand side, where we're demonstrating that growth, that there is significant variability from strain to strain. And in fact, some strains don't grow well at all. And that is unfortunately more true for usually lung infections than thigh. So in the thigh model, almost 70% had a greater than 1 log growth. In the lung, it was only about 40%. But we were able to find, again, 5 relatively fit isolates that all grew to the same extent within the model and grew well in both thigh and lung, not just one of the infection sites. And those 5 strains are shown at the bottom. And again, the MIC values are listed there, but they were on the previous slide as well. So we performed plasma and ELF PK in the mice. These were the different doses that we used for the 4 drugs. This is relatively, standard procedure. We have a 4-fold increasing dose range in the mice. We have, quite a large amount of sample times that were done, and plasma and ELF pharmacokinetics were measured at all those time points. I should note that I won't go into the methods necessarily, but for the ELF PK, it was done by urea correction methods. So here are the various PK figures. We'll walk through each of them. Along the y-axis is the concentration measured. Along the x-axis is time. You have each of the 4 doses represented, and we put in the figure legends here some of the PK parameters of interest, just if you want to look at them. I think what helps in these figures is to look between the plasma and ELF and get an idea for how similar they are. In other words, whether the penetration was close to 100% or kind of how the penetration worked out. So for amikacin, for example, here, it is certainly more than 50%, probably somewhere around 60 to 65% of the exposure that we saw in plasma you see in ELF. And that's also true in the human data, and we'll talk a little bit about that in a few slides. For ceftazidime, here's the plasma and ELF concentrations. You'll probably appreciate that this is different than the amikacin in that the half-life is very short, which is true for beta-lactams in general in the mice, and the relative amount that penetrated into ELF was far less, and this is also true in humans. And we'll come back to this when we talk about setting susceptibility breakpoints, because the low penetration into the ELF ended up being a factor in terms of how we set our breakpoints. For Cipro, plasma and ELF shown here, they were relatively flat. One reason perhaps for this, as it might look different than some of the other ciprofloxacin mouse PK studies, is in order to achieve the dose range that we needed to achieve, we were not able to use the intravenous formulation and had to use a powder formulation that had a much slower absorption into the systemic circulation from subcutaneous exposure. And then finally, minocycline is shown here, plasma on the left, ELF on the right. And as is true for many tetracyclines, you'll probably appreciate that the penetration into ELF was quite good, which was true for ciprofloxacin as well. So moving past the PK and getting into the thigh and lung treatment studies. So again, to just reiterate, we had these 4 drugs. We had 5 Acinetobacter strains. We looked at neutropenic mouse lung and thigh infection models. And we used the kind of traditional Emax Hill sigmoid dose response equation to look at things such as stasis, 1 log kill. You'll even see some 2 log kill data in some of this, but primarily stasis and 1 log kill. And we'll also touch on in the end why we picked 1 log kill as the target attainment target. The drug range is shown here in the dosing intervals as well. So there's going to be a number of slides here on the different drugs and the different models. We'll kind of go one by one. They're going to be set up similarly. So hopefully, after you kind of understand the setup of this first slide, the other ones will make a lot of sense. So on the left-hand side of each slide will be dose response data, where the drug dose is listed across the x-axis and the microbiological outcome is listed on the y-axis. The dashed line at 0 is net stasis. So points above the line is net growth, points below the line is net cytal activity. And what you want to look for and what you see here, hopefully, is that, you see a dose response. So as the dose is increasing, you see increasing microbiological effect in the animal. On the right-hand side, the graph is set up similarly, with the only section or the only difference being that the x-axis now has been replaced by the PK/PD parameter of interest for that drug. So for aminoglycosides, AUC to MIC. So we've taken all of the data on the left, and we've taken those doses and we've converted them into an AUC to MIC. You plot the data, and you can see a nice sigmoid relationship, which is what you would hope to find or expect to find. As AUC to MIC increases, you get increasing effect. In the table below, we're just showing some of the PK/PD target data, and this is summary data. So it's mean, median, and standard deviation for the 5 strains. So you have the total dose that was necessary for stasis, and then for that total dose, what was the AUC to MIC for total drug, and what was the AUC to MIC for free drug. So that's shown here for stasis in the left-hand side, and then 1 log kill in the right-hand side. And so, for example, a 1 log kill for amikacin in the thigh model was, somewhere between 12 to 18, depending on whether you looked at the mean or the median. So here's the lung data. Again, the figures are the same as before, with the exception that the PK/PD driver we're showing you along the x-axis is ELF AUC to MIC. So here's amikacin in the lung. We saw a slightly improved effect in the lung compared to the thigh. And we're then again showing the summary data in the table. The one thing to point out here is we're showing you the ELF AUC to MIC target data, which is kind of in the middle column for stasis and 1 log kill. And we're also showing you what the associated plasma exposure would be for that outcome. And so, for example, if you remember, amikacin ELF penetration was somewhere around 60%-ish or so. And so consequently, the ELF AUC to MIC, if it's a value of 3, for example, for stasis, the plasma value is going to be a little bit higher because obviously the plasma levels are higher. And so that target is, approximately 4.7, again, for example, for stasis. Ceftazidime in the thigh and lung, you'll see in the next slide, was I think surprised us somewhat. It was very effective, and that's obvious here given the time above MIC that was needed for net stasis and 1 log kill. So, for example, for ceftazidime in the thigh, a 1 log kill was seen somewhere around a 20% time above MIC. And in the lung model, similarly, in fact, slightly more effective, the plasma free time above MIC that was associated with the 1 log kill was something more, closer to 15%. Here's Cipro in the thigh. It was, quite effective, and you can see actually a very, very nice sigmoid relationship between ciprofloxacin free drug AUC to MIC and treatment effect. When you look at the PK/PD targets here, probably the thing to note is that these are quite a bit less than what we have seen previously for things like E. coli or Klebsiella or Pseudomonas, other gram-negative types of infections, although certainly different PK/PD targets exist for different organisms. So here, for example, 1 log kill was an AUC to MIC, I should say free drug AUC to MIC, somewhere around 17. And for lung, we saw very similar results in terms of targets and therapeutic effect. Again, here shown lung. There's the free drug plasma AUC to MIC was similar to the thigh model at a value of around 16, and for 1 log kill, and for the ELF AUC to MIC was around 20. And finally, minocycline, which of all the drugs and all the models, we probably saw the most variability for minocycline in the thigh model, and that actually carried forward into some of our target attainment, you'll see. So here is the minocycline thigh data. Relatively low free drug AUC to MIC was associated with both net stasis and 1 log kill. So, for example, 1 log kill, the mean free AUC to MIC was 9.1. And in the lung model, the numbers were similarly low. And again, with the relatively good penetration of this drug into ELF and the plasma and ELF levels being relatively similar, there's really not a lot of difference that you'll notice between ELF AUC to MIC, or if you're looking at plasma free drug AUC to MIC. Again, relatively low target numbers here, though, at 5, for example, for 1 log kill. So that's a lot of animal model data, and that's not the only thing that, you know, we need to focus on or talk about. So I'm going to move forward to some of the integration now with population PK calculations and Monte Carlo simulation. And what I'm showing you on this slide are the methods by which the population PK and patient simulation was done. So simulated patients with complicated UTI or acute pyelonephritis and HAP-FAP were generated using demographic data from clinical trials. So typical PK values were simulated and calculated using demographic data. And I have a few extra slides here for those that are interested in seeing, you know, some of the covariates and so forth. But suffice it to say that the simulated patients received the maximal dosing, and we're showing that on the right-hand side here, not only what the dosing was that was simulated, but also what some of the adjustments were made for renal impairment when necessary. And in the end, we looked at the percent probabilities of attaining median and randomly assigned PK/PD targets associated with a 1 log CFU reduction from baseline. And I'll touch on that in just a second in terms of how we arrived at you know, picking which outcome from the animal model to use, as well as how, you know, exactly what the rationale was for using median versus randomly assigned. So this table is purely in for those that are interested. I don't expect, you know, all of you to read through it in depth per se, but you know, this is a summary of the parameter estimates for, you know, for each drug listed here and some of the analytical methods that were used and so forth. And as well, here's some relevant covariates that were taken from the complicated UTI or acute pyelonephritis studies versus HAP-FAP. And again, a lot of data here. It's not, you know, it's not that you would absorb all of this necessarily just by looking. ELF penetration. So I mentioned that we would touch on this again. So, and interestingly, in the animal model, we had numbers very similar to this, but in humans, here's the ELF penetration. And as you'll probably note, it's quite good for fluoroquinolones and tetracyclines. It's you know, not that bad for amikacin, about 60%, and for ceftazidime, it's pretty poor at only 23%. So integrating the PK/PD targets, and I mentioned we'd come back to this. So we utilized targets associated with a 1 log kill endpoint in the animal model. So why did we do this? You know, we felt this was the best target endpoint, given that much of Acinetobacter infections are pulmonary and or high burden infections with often limited ability to really optimally source control them. And so in those situations, most of the time, the 1 log kill target has correlated best with clinical efficacy. Now, in terms of looking at median versus random assignment, I wanted to touch on that briefly because that might be something new to many of you in terms of what you might have seen in the past. So we used 2 methods here. So one, and I'm showing you that hopefully in the table below it, that one way to do it is to take the median PK/PD target value. So for I'm showing you one example here for amikacin. So for amikacin, the median free drug plasma AUC to MIC ratio associated with a 1 log kill was 12.2. So one way to do it is take that median value and apply that in your simulated patient analysis. Another method that adds some variability, which is important clinically, is to randomly assign the PK/PD targets that you found in your animal model study for each strain, to randomly assign one of those to each simulated patient. And so that would be represented by all the blue numbers there, is that those would get randomly assigned to each patient in the simulation. There's pluses and minuses to each of them, you know, to doing it each way. But you know, it is 2 methods to apply your animal model PK/PD targets. And then finally, we examine the attainment associated with 5 model plasma exposure targets So thigh model, plasma exposure. And then the lung model, we did it two different ways. We have lung model plasma exposure targets and lung model ELF exposure targets. Again, all associated with the one log kill target. So you end up with a lot of tables that can look like this that, many of you may have seen before. And I'm not going to show you all the tables because it would take quite a long time, but this is an example of a table of a table showing various target attainments. So the MIC value is shown on the left, and then you have, based on either stasis, one log kill, two log kill, etc., you have target attainment probabilities. And in this case, this is using the median free drug plasma PK/PD target from the murine thigh infection model. And the differences in shading is just to demonstrate areas where you're above 90% target attainment versus areas where you're below 90% target attainment. And so you can do that in this case for the median free drug plasma PK/PD target in the thigh infection model. And then you can do it as a randomly assigned free drug plasma PK/PD target in the murine thigh infection model. And then you would do that as well for the pulmonary infection models using plasma or ELF. But what I'd rather show you are the figures, because I think many of you are probably more used to seeing figures like this one on the left. Perhaps maybe not as many lines or as complicated as this. So I'm gonna take a minute or two to kind of walk through how the figure is set up. So on the primary y-axis, that's the left-hand y-axis, is the probability of PK/PD target attainment, so from 0 to 100%. And on the secondary y-axis, which is the right-hand side, is the relative frequency of MIC distribution. And we're showing you just United States Acinetobacter isolates, the distribution of all isolates shown in gray, and then the distribution of carbapenem-resistant isolates shown in orange. And that's, those are the histogram kind of running across the bottom. And that's just so that you get an idea of where the distribution exists. Now, the different lines are the following. So again, we did PK/PD target assessment based on the median PK/PD target that we found in the animal model, and then randomly assigning a PK/PD target from one of the 5 isolates. And then we have thigh free drug plasma, that's the blue, lung free drug plasma, that's the green, and lung total drug ELF, and that's the red. So you can have 6 lines here for each model and for each type of drug exposure, plasma or ELF, and taking into account whether you're looking at median or randomly assigned. And what I'm showing you on the right is the kind of USCAST current kind of stick based on the analysis of all this data to kind of put into context where we kind of drew some of these lines in terms of what would be a reasonable breakpoint we feel based on this pharmacometric analysis. And so what you'll see here is that, when you get up to an MIC of 8, almost all of the various types of modeling, you're still well above 90% probability of target attainment. The only exception is the randomly assigned thigh model, where you would be about 86, 87%. So, but given that the vast majority of the models were well above 90%, that was, one of the main reasons for picking less than or equal to 8 as the kind of proposed breakpoint based on this type of work. You can see once you get to 16, quite a few different analyses are well below 90%. Here's ceftazidime. With ceftazidime, we ran into an issue with trying to generate all of the various models. And so that's, you'll kind of notice there are less lines here, right? There's the solid, red, green, and blue, but there's only a dash blue. And, the reason there's no red or green dash line is attempted to be explained in the left-hand side here, that, there were some ceftazidime percent time of MICU targets that included a value of 0. And so we didn't do random assignment for those situations. because we just had an inability to estimate a log normal distribution, so we just couldn't do it. So there are not randomly assigned targets here for the lung model because some of those time above MIC targets were 0. But we do have the other models here. So we have the thigh, both median and randomly assigned in blue, and the lung free drug plasma shown in green, and the lung total drug ELF shown in red. And you'll note a divergence here, and perhaps, you know, related to the fact that ceftazidime does not get into ELF very well. The target attainment for ceftazidime was quite a bit lower for the total drug ELF. And that actually led us to propose the possibility of having a pneumonia breakpoint for ceftazidime of less than or equal to 8, where you're still well above 90%, as hopefully you'll appreciate here. But for other situations, the target attainment up to an MIC of 32 was quite positive, as they're all above 90% until you hit 64. Here is ciprofloxacin. You can see the lines in general overlap quite consistently. There's at an MIC value of 1, there are 2 of the red points that are barely under 90%. It's like 88 to 89%. But because most of the models and most of the data at an MIC value of 1 is at 90% or above 90%, we felt that a proposed breakpoint of less than or equal to 1 made the most sense for that. And then for minocycline, again, this is where we saw perhaps the most variability in the animal model data, and it bears out when you look at median PK/PD target assessment versus randomly assigned. So if you look at the blue solid line versus the blue dash line, I mean, I don't think it's rocket science to say, boy, there's quite a difference there. And that is because, especially for one particular organism from minocycline, it had a very, very high PK/PD target in comparison to the rest. And so that led to divergence, at least when you looked at a median target versus a randomly assigned. If you look at the lung, we had less variability there. And because minocycline has 2 different dosing regimens that may be used, you know, people may do 200 twice a day versus 200 once a day. There actually are 2 breakpoints listed, one for a traditional dose or regular dose, if you will, and one for a quote unquote high dose. The figure that we're showing you here on the left is for high dosing, so twice daily IV minocycline. And for that, we felt a breakpoint less than or equal to 1 made the most sense, although, you know, as you probably can note from looking at the figure, making a breakpoint determination for minocycline was not as easy as the rest. So I'm gonna leave this slide up for perhaps, you know, 30 seconds or so to just have you absorb it. It's pretty self-explanatory. We're just trying to demonstrate what our interpretation of the PK/PD data that we've demonstrated here and doing the pharmacometric analyses and target attainment, what we feel would be reasonable breakpoints for amikacin, ceftazidime, ciprofloxacin, and minocycline, and then what some of the other groups or societies have suggested in terms of breakpoints. You know, obviously for some drugs there are not breakpoints, or for some situations there are not breakpoints suggested. I think an interesting thing to note is that for the most part, with the exception of minocycline, for the most part, they're relatively close. So, you know, there aren't a huge number of differences. Again, I think the exception is minocycline. And then I'm just going to quickly go through these. I think visually these help think about where these proposed breakpoints would sit in terms of distributions. So if we had a breakpoint for amikacin at less than or equal to 8, about 80% of the isolates in the United States would be expected to be susceptible. Only 47.5% of isolates in the US that were carbapenem-resistant Acinetobacter would be expected to be susceptible, so quite a bit of drop-off for carbapenem-resistant isolates. This is ceftazidime using the non-pneumonia breakpoint of 32. 77% in the US would be expected to be susceptible. Of those that are carbapenem resistant, only 38%. If we look at the pneumonia breakpoint, it would obviously drop quite a bit. If you look at ciprofloxacin, again, in the United States, many would be susceptible, 61%. However, for carbapenem resistant organisms, only 2%. And finally, for minocycline, depending on whether you looked at a high or a standard dose, again, many of the Acinetobacter isolates would be susceptible, somewhere between 2/3 and 3/4, but for the carbapenem resistant ones, quite a bit of drop off. So this is my last slide. I think the conclusions are, using this approach, we were able to find reasonable suggested breakpoints for these 4 drugs. We expect that these results and that, if these breakpoints are instituted, that it will positively impact rational drug use for these infections, which is really critically important for older drugs. If you don't know how to use them well, then they can unfortunately get used in situations where they shouldn't be, and we should be thinking about using different therapies, newer therapies, and so forth. As I mentioned, the clinical data examining efficacy in the context of PK exposures for these drugs and discrete MIC data are very limited, and they would certainly help a lot in terms of putting some of these breakpoint suggestions into context with better clinical data. And then finally, I think, the data demonstrates that in the United States, even, it's not expected that these 4 drugs will be particularly good coverage or have high likelihoods of success for drug-resistant Acinetobacter infections, especially carbapenem-resistant ones. And so, I think it does highlight that, at least in terms of ongoing drug development and ongoing work, we still have a lot of work to find good therapies for patients with carbapenem-resistant infections, and we need to continue to optimize dosing strategies and novel therapies for those infections. So I'm the one presenting this, but there's lots of people on this call that were involved. It was a huge group that kind of helped see this to fruition. And some of the critical people are listed here on this slide, but certainly big thanks to everyone that helped out, and everyone with USCAST for helping us see this through.
All right. Thank you, Alex. That was fantastic. One question I think that would be good for the audience that was brought up is just a clarification. Were these isolates carbapenem resistant, carbapenem susceptible, or both?
That's a good question. I don't recall exactly if they were, and I don't know if we had it in the slide or not. Yeah, I don't recall what the status of their carbapenem susceptibility was.
Okay, so we will get back with, when we post the slides in the future, we'll make sure that we address that so that everyone's aware. But thank you for that comment, and thank you, Alex, for the answer. I don't see anything else that needs addressed by you right now. So thank you, Alex. And again, if anybody else has other comments, other thoughts, other feedback for Alex to address, please let us know. You can do it. You can still do it in the comments now, or you can do it afterwards. But Alex, I think you're off the hook.